Hello and good evening, everybody. Welcome to the UKIO Obs and Gynae session. Today's session is on pelvic pain, and we have two great speakers for you this evening. The first speaker is Dr. Sue Freeman, who works at Addenbrooke's in Cambridge. Her interest is gynecological imaging, both benign and malignant, and she's the lead for gynae imaging at Addenbrooke's. Today she's going to speak to us on chronic pelvic pain, and it gives her a chance to speak about one of her interests, special interests in endometriosis. I'm going to pass you over to Sue's lecture now.
Thanks very much to the UKIO Organising Committee and to Nish for inviting me to speak today. We're going to be looking at the role of imaging in chronic pelvic pain, and it's such an important subject because if we think about it, so much of our time in the radiology department and in gynecology clinics are spent trying to solve this problem, but perhaps it's not quite so frequently covered in conferences like this when compared with acute pelvic pain. We're going to review the definition of chronic pelvic pain and explore the common causes of it, and I'm going to use some cases to really explore how we use the different imaging modalities to problem solve and to illustrate some of the common imaging findings for these gynecological pathologies. Even the definition of chronic pelvic pain isn't universally agreed, and it has several different definitions in the literature. So these are some of the most commonly acknowledged definitions. So first one, chronic pelvic pain of 6 months or more. That's fine, but what if the patient had pelvic pain for 5.5 months? Period pain more intense than a normal period, perhaps longer than a normal period. That seems to make sense. It could be continuous or intermittent. And I think many would also include symptoms which are severe enough to interfere with a woman's quality of life. Chronic pelvic pain is extremely common, affecting 1 in 6 women during their lifetime, and is often multifactorial. There's a list here of non-gynecological causes. The pelvis is such a complex anatomical place, including uterus, ovaries, bladder, bowel, muscles, nerves, bones, joints. And so it can be very difficult to clearly identify which particular organ is causing the pain. So you can see here some of the very common causes of chronic pelvic pain. Irritable bowel syndrome. How about bladder pain syndrome? And of course, don't forget there could also be a psychological component. Depression and sleep disorders may commonly be found, but they may be a consequence rather than a cause of the pain. These ladies have often been undiagnosed for quite some time. So in real life, the pelvis can't be thought of in silos because of this multifactorial nature of chronic pelvic pain. But for the purposes of this lecture, I'm going to limit myself to talking about the gynae causes. We can construct long lists of possible gynecological diagnoses, but common things are common, and therefore for my list I would put endometriosis in first, second and third positions. After that, adenomyosis, chronic pelvic inflammatory disease, and then onto pelvic inclusion cyst. Some people would include prolapse and fibroids on this list. I'm not going to talk about them today because I think they have a particular constellation of symptoms which are usually quite indicative. Fibroids tend to give pressure symptoms unless there's acute degeneration or torsion, in which case this presents with acute pelvic pain. In addition, pelvic congestion syndrome, my next speaker is going to be talking about that, so I won't be talking about pelvic congestion syndrome during this lecture. And also, I'm not going to be talking about gynae malignancy. That is covered well in so many different lectures, and it's just to say that if a woman comes with persistent bloating, early satiety, abdominal pelvic pain, increased urinary urgency, GPs need to be sending CA125 and requesting a pelvic ultrasound. Also, new onset irritable bowel syndrome in women over 50 should be investigated, just so that we should exclude ovarian and bowel cancer. The ultrasound is always the first imaging investigation of choice, and as clinicians it's essential that we can glean as much information as we can from the examination. So remember to talk to the patient and find out what sort of pain. Is it sharp, dull, dragging? Does it radiate anywhere? Is it constant, cyclical? Does it affect the bladder or the bowel? Is there dyspareunia, heavy periods? And importantly, has there been a previous history of any surgery or pelvic inflammation? So it is important that we use the same ultrasound method with every patient so that we avoid missing pathology. And I also use a standardised report just to make sure that that information is accurately recorded. So as I said, we're going to base our discussion around a series of cases so that we can highlight the imaging aspects that we will come across as clinicians. This is our first case. So a 38-year-old female was referred for a pelvic ultrasound. She had experienced chronic pelvic pain for several years. However, she had recently had an increase in pelvic discussion and some bloating. Her GP checked the CA125 level and that was raised at 90, and all her other blood tests were normal. Her transabdominal ultrasound revealed this appearance. If we look at the red line, we can see that the cervix is anteverted, but the yellow dotted line shows that the uterine body is retroflexed. This uterine position on transabdominal ultrasound can alert us to the possibility of underlying endometriosis. We need to be really aware and carefully look for endometriosis on the transvaginal ultrasound. Transvaginal ultrasound immediately revealed this appearance. It is a hypoechoic nodule which is invading into the anterior rectum, and this is a large muscle invasive endometriotic deposit, and it's indicated with the white arrow. There's also a further retrocervical deposit indicated by the green arrow. Now, the uterine position, again, you can see that it's retroflex, so there's going to be an element of fibrosis along the posterior aspect of the uterine body and cervix. If we move our ultrasound probe from the anterior vaginal fornix into the posterior vaginal fornix, we'll be able to see even more clearly that bowel invasive deposit and see the relationship with that and the retrocervical deposit. On direct questioning, the patient revealed that she had severe rectal pain during her period and occasional PR bleeding. So that just confirmed absolutely what we could see. So the MR image on the left is a T2 weighted sagittal image of the same patient. And next to it on the right, I've inverted the ultrasound image so that we can do direct comparison. And the MR shows this large muscle invasive bowel endometriotic deposit, and what it represents is an ectopic endometrial gland that has landed on the bowel surface and has set up fibromuscular hyperplasia around itself. It's been described as either a mushroom cap or fan-shaped lesion, and it's always low signal intensity on T2 and T1 weighted imaging. This is because of the fibrous and muscular components within it. Occasionally it does have blood products within the lesion, in which case you will see a little bit of high signal intensity, mainly on T1 weighted imaging with fat saturation. In this case, the ultrasound was able to completely make the diagnosis, and MRI was only used in the preoperative planning of the patient. It's important that we fully understand how much of the bowel is involved. if it's just this section or are there any other lesions. And by using the two methods together, we can accurately plan surgery and also give preoperative counselling. Will this patient need just shaving of the lesion, a disc resection, or will she need a segmental bowel resection, which may ultimately involve needing a temporary stoma? All this information is really important, and we can plan accurately from the MRI. So this is a quick reminder about endometriosis, the presence of functioning endometrial glands and stroma outside of the uterus. And it can be differentiated into superficial and deep endometriosis. The superficial endometriosis is commonly not seen on imaging and best diagnosed at laparoscopy if it's required. Ultrasound is very sensitive for diagnosing endometriomas, which we can see as cysts with homogeneous low-level echoes. We can see in the image at the top there. Other ultrasound features of deep invasive endometriosis include these hypoechoic endometriotic nodules involving bladder or bowel. But also remember that endometriosis causes fibrosis and adhesions within the pelvis, and therefore we may see the effect of those adhesions, including adhesions between the uterus and ovaries, causing kissing ovaries, where they are sited in the pouch of Douglas behind the uterus. And also remember that the symptoms of endometriosis closely correlate the site of disease. So again, make the most of your ultrasound examination and talk to the patient and carefully listen to see whether or not there is any particular areas of discomfort. So let's discuss the standard ultrasound examination for endometriosis. So perform your normal transvaginal ultrasound with your position of the uterus. Think about retroflexion. Look at the endometrium. The myometrium are the only features of adenomyosis. Look at the tubes and ovaries. Is there an endometrioma, like we can see here on the middle image? Is there hydrosalpinx or hematosalpinx? And look at the position of the ovaries. So here we can see the ovaries are touching one another within the pouch of Douglas behind the uterus. They're kissing ovaries. And are they mobile? So this bottom left image shows that the left ovary is abutting the uterine body. The ultrasound probe can be used to apply pressure to see whether the ovary can move separately from the uterus or whether there is truly an adhesion at this site. And specifically look for the uterine sliding sign. With the ultrasound probe in the anterior vaginal fornix, apply pressure with your other hand to the anterior abdominal wall. Watch the uterus sliding smoothly past the structures in the retrouterine pouch. And if the uterus doesn't slide smoothly, this implies the presence of adhesions in the pouch of Douglas. We now need to place the ultrasound probe carefully into the posterior vaginal fornix. If this manoeuvre is uncomfortable for the patient, please look very, very carefully for endometriosis. And it's with the probe in this position, we now need to look at the torus uterinus, which is the junction between the uterine body and the cervix. It's probably the most common place to find endometriotic deposits. Once you've found the torus uterinus, it's important to sweep left and right from this point along where you imagine the uterosacral ligaments to be. Look for hypoechoic nodules, and importantly, listen to the patient to see if there are any trigger points. The figure on the right is indicating with the white arrow the retrocervical nodule, which is on the left uterosacral ligament. And these patients commonly complain of dyspareunia. Carefully examine the anterior serosa of the rectum now. Go all the way up as far as you can to the sigmoid, looking for hypoechoic nodules. And now for this patient, top right, you can see this large rectal endometriotic nodule, even with the probe in the anterior vaginal fornix, indicated with the white arrow. But by moving the probe into the posterior vaginal fornix, we are better able to see the extent of the lesion, and also indicated by the red arrow, the nodule extending forward to involve the posterior vaginal fornix. Now it's almost time to end the procedure, so as you slowly move the probe, look at the bladder sliding past the uterus. It's common to see adhesions in women who have previously had a caesarean section. Look for bladder invasive nodules. And with practice, you can start to look at the parametria and the distal ureters. But for simplicity, it's very easy just to look at the kidneys on transabdominal ultrasound to look for hydronephrosis. So this is a companion case so that we can explore the imaging features a little bit more. This is a 32-year-old female who was referred with cyclical left pelvic pain, and it was highly suggestive of endometriosis. But her pelvic ultrasound was completely normal. We can see a normal uterus, endometrium, kidneys, ovaries, all completely normal. But given that her symptoms were increasing and this strong suspicion that there was underlying endometriosis, she went on to have an MRI. So this is a sagittal T2 weighted image which shows a completely normal anteverted uterus. The endometrium and myometrium are unremarkable, so this completely confirms the findings from the ultrasound. However, this parasagittal slice over towards the left pelvic sidewall shows this low signal intensity lesion involving the mid-sigmoid colon. The white arrow shows the bowel invasive endometriotic deposit, and these red arrows demonstrate moderate left hydroureter. The axial and coronal views that I'm now showing demonstrate the bowel invasive endometriotic deposit indicated by an asterisk. And there is fibrosis and tethering all the way over to the pelvic sidewall, shown by the white arrows. And I think this now explains why it wasn't clearly seen on ultrasound, because the bowel and bowel gas are on the other side of the lesion, leaving these deposits completely hidden by bowel gas, by the overlying bowel structures. You can see that the fibrosis extends to the pelvic sidewall and to very close to the adjacent nerves. And she occasionally complained of pain radiating down her thigh. And also the deposit is extending anteriorly to involve the distal left ureter, which is becoming slightly dilated, shown by the red arrow. And it's a perfect example where MRI is an adjunct to ultrasound. So ultrasound will diagnose many patients very accurately with endometriosis if it's performed properly. But in those where it's non-informative but the history is very suggestive, MRI can be used to make the diagnosis. MRI is highly sensitive and specific for diagnosing endometriosis, and almost 100% specific for endometriomas. You can see the T2 weighted image demonstrates shading where the lesion goes from light grey down to dark grey, and that's because of the high iron content within the endometrioma due to repeated episodes of bleeding. On the right hand side, the endometrioma is high signal intensity on T1 and T1 weighted with fat saturation. This is absolutely pathognomonic of an endometrioma and can be very helpful if occasionally the ultrasound is indeterminate. Once you identify an endometrioma, it is important to look very, very carefully for bowel involvement with endometriosis, as this gives an increased risk. The MRI provides an excellent roadmap prior to surgery, and within the context of an MDT, the ability to scroll through images is often preferred by the colorectal and urology surgeons who may not understand the pelvic ultrasound as well as the radiology and gynecology team. And of course, we use the MRI to determine what sort of surgery the patient is likely to need. So again, in this case on the right, we can see a large rectosigmoid deposit indicated with the white arrow. That was easily seen on ultrasound. But what the MRI revealed was the presence of a further lesion within the small bowel, which is causing a degree of obstruction indicated by the red arrow. Bladder invasion is well seen on both ultrasound and MRI, but the MRI helps assess the extent of VUJ involvement, ureteric involvement, and the parametria, whether there's fibrosis causing medialization of the ureters. This is a fibrotic lesion which is extending out to the pelvic sidewall and is causing a hydroureter. So this is an extrinsic effect. Sometimes we may see an intrinsic lesion involved in the ureteric wall itself. The CA125 is often raised in endometriosis, and MRI is excellent in adnexal mass characterization, and it can confirm or exclude the presence of endometriosis-associated malignancy. In this case, the arrow points to a mural nodule that demonstrates enhancement with intravenous gadolinium, confirming the presence of malignancy. And on histology, this was shown to be an endometrioid adenocarcinoma. We have spent quite a while looking at the imaging of endometriosis, but I think that that is important because it's by far the commonest cause of chronic pelvic pain that you will see on a weekly basis in your ultrasound clinic. So well worth spending time. Let's move on to another case of chronic pelvic pain. This is a 46-year-old female who presented with heavy menstrual bleeding and chronic pelvic pain. Her GP had sent her CA125, which came back as slightly raised at 45. So she came for an ultrasound and said that she'd previously been told that she had fibroids. And this is the first transabdominal ultrasound of the uterine body. And you can see that it does appear enlarged and it does have a globular football shape. The anterior myometrium, however, is focally thickened, indicated by these white arrows. It looks slightly heterogeneous, and we can see that the endometrium is displaced posteriorly, indicated by this red line. Again, the transabdominal transverse view of the uterus shows a very heterogeneous appearance of the myometrium. Moving on to the transvaginal ultrasound, this confirmed the findings of the transabdominal ultrasound. There wasn't really a convincing focal mass that could be identified to suggest a fibroid. And if we look carefully, these arrows demonstrate cystic spaces within the anterior myometrium. These arrows demonstrate parallel striations known as a rain shower or Venetian blind appearance. And this is pathognomonic for adenomyosis. Other features that we might see on ultrasound include heterogeneous myometrium, ill definition of the endometrial myometrial junction, and this asymmetry that we see between the anterior and posterior myometrium. In cases like this, an MRI isn't needed to confirm the diagnosis, but can be very useful in indeterminate cases. For this patient, she had an MRI because the surgeons were still chasing the raised CA125. And we can see the axial image on the right shows two completely normal ovaries. But it is a nice case because it demonstrates clearly the same findings that we see on the ultrasound. The anterior myometrium is thickened. There are multiple high signal intensity foci within the myometrium which represent the endometrial glands. Occasionally they contain blood products, which is best seen on the T1 weighted with fat saturation imaging. This is the pathological specimen for the same patient, demonstrating exactly the same features again. You can see clearly these endometrial glands within the myometrium. So adenomyosis is, as we've said, the presence of endometrial glands within the myometrium. It is very common, and different studies of post-hysterectomy samples have identified adenomyosis in up to 70% of cases. Typically, the age range is 40 to 50 years, but it can be seen earlier than that, particularly on MRI. It presents with heavy menstrual bleeding and dysmenorrhea. And depending on which studies you read, both ultrasound and MRI are fairly sensitive and specific for diagnosing adenomyosis. Adenomyosis is commonly thought of in two different forms, focal and diffuse, and the most frequent finding to see on MRI is thickening of the junctional zone, which is the inner myometrium, this low signal intensity rim that we see around the endometrium. Less than 8 millimeters is considered completely normal, and 12 millimeters or more is considered diagnostic of diffuse adenomyosis. Between those figures, between 8 and 12 millimeters, we need to look for other signs that help us to make the diagnosis. In particular, if there are the presence of high signal intensity foci on either T1 or T2 weighted imaging, that would push us towards the diagnosis. So you can see here on the bottom image, the double-ended arrow shows thickening of the junctional zone and also the presence of multiple high signal intensity foci within it. Focal adenomyosis, on the other hand, is commonly mistaken for fibroids, but we need to look at it carefully. They have a much less distinct margin, and they also may have these high signal intensity foci within them representing the endometrial glands. Adenomyosis has been reported as commonly found in patients with fibroids. In studies looking at hysterectomy specimens of women with known fibroids, up to 57% of cases showed concomitant adenomyosis. And this is demonstrated on this image here on the right. So a bulky fibroid uterus, the fibroids are well circumscribed, low signal intensity lesions. But the arrows are demonstrating a focal adenomyoma. The margins are much less distinct, and there are multiple high signal intensity foci within it. Leyenbecker et al. Found the prevalence of endometriosis in patients with adenomyosis to be 80%, and the prevalence of adenomyosis in endometriosis to be 91%. So these two entities are commonly coexisting, although the pathological cause for this isn't currently understood. So we've spent some time looking at endometriosis and adenomyosis, and we're going to move away from that completely now and move on to our third case. This is a 44-year-old female referred by her GP with left iliac fossa pain for several months. She'd had some change in bowel habit, and of note, she had had a copper coil in situ for 11 years. Her CA125 was normal, but her CRP and white cell counts were slightly raised, and she had mild anemia. Her urinary sample showed lots of white cells, but no growth, and the vaginal swabs were negative. This is a transabdominal ultrasound, which the top image shows the coil in situ, and the bottom image shows a complex left ovarian cyst. Reviewing her kidneys, there was no hydronephrosis. The transvaginal ultrasound shows a 6 by 6 centimetre left adnexal cyst. You can see part of it is completely simple, anechoic fluid, but the other part shows internal echoes and possibly some soft tissue, but there was no vascularity seen on Doppler imaging. So in the context of her clinical presentation and the coil, it was felt to be most likely to represent a tubovarian abscess. Her coil was removed and she was treated with antibiotics. However, she represents 2 months later with increasing left pelvic pain, and she had a palpable mass on the left side. The gynecologist requested an MRI, which shows this image here. Between the arrowheads is the complex left ovarian cyst, which is part simple high signal intensity fluid and part intermediate signal intensity, which you can see extends beyond the bounds of the ovary out towards the pelvic sidewall. The intermediate signal intensity lesion can be seen extending up towards the left iliac fossa, indicated by this upper arrow, and this red arrow demonstrates the mass fistulating into the adjacent sigmoid colon. The fat within the pelvis is indurated, and you can see stranding throughout the pelvis. and we can now see a sagittal T2 weighted image out towards the left pelvic sidewall, which shows the left pelvic mass, and the arrows indicate a left hydroureter. Again, note how indurated the fat within the pelvis is. The abnormal intermediate signal intensity seen on the T2 weighted image has corresponding restricted diffusion on DWI and ADC map. You can see it's high signal intensity on DWI and low signal intensity on ADC map. So this appearance would then be commonly mistaken for malignancy, but please don't forget that we also see restricted diffusion in abscesses. And the prior intrauterine device was a clue for this diagnosis, which I'm sure you've all guessed is actinomycosis, absolutely. So this patient underwent a sigmoidoscopy to investigate the fistula further, but it was macroscopically normal and the random biopsies were also normal. Vaginal swabs were negative, and unfortunately when the coil was removed it wasn't sent for culture. And that's quite typical. Unless you use absolutely the right conditions for growing actinomycosis, it often comes back as negative, and that's where the imaging is so important in making this diagnosis. This is typical low signal intensity. It doesn't conform to anatomical boundaries, and we often see fistulation into bladder or bowel. This infection requires a long course of antibiotics of 6 to 12 months. And this is the MR appearance after 6 months of antibiotics. You can see that the adnexal mass has reduced down with just some normal follicles demonstrated. The fat induration has resolved and the bowel is now back to normal with no fistulation demonstrated. The patient has normal FBC and CRP. Chronic pelvic inflammatory disease is different to acute PID. Common causes of acute PID would include chlamydia, Neisseria and Gardnerella vaginalis. And when acute PID occurs, it's often acute pelvic pain, high fever, peritonism, and these patients come into the emergency department with suspected appendicitis and can often have a CT scan. You can see at the top here, the patient with Crury appendicitis shows a grossly thickened left fallopian tube with fluid in the pelvis and fat stranding. And the bottom image is the same patient a little while later, again still showing on this coronal T2 weighted image that thickened, dilated left fallopian tube. So thinking about chronic PID, it may still be the same infections from acute PID, but also consider conditions such as actinomycosis, which is a gram-positive anaerobic bacteria. And if pathological specimens are possible, they would reveal sulfur granules to make the diagnosis. And this image on the top, sagittal T2 weighted image, shows another different case with actinomycosis, this mass-like appearance. Don't forget tuberculosis, and this CT image at the bottom demonstrates a fluid-filled distended uterine cavity secondary to TB endometritis. There is ascites and peritoneal enhancement consistent with peritonitis. So you can see how both of these cases could be mistaken for malignancy, and it's important that as radiologists we keep an open mind and consider the presence of chronic infections in our diagnosis. And now finally, let's move on to our last case of chronic pelvic pain. This patient had persistent low-grade pelvic pain. She described it as a knotted feeling in her pelvis and had completely normal bloods. She did, of note, have a previous history of a myomectomy, and this is her transabdominal ultrasound image. This measures 15 centimetres and it shows some internal complexity with septations, and it shows a solid nodule with associated vascularity on Doppler imaging. So she went on to have an MRI to characterise this further. and the MRI confirmed a large pelvic cystic lesion. It's predominantly on the left side and extends up into the left iliac fossa. And within the cyst, again, we can see these septations. But if we look closely, this solid nodule, I think you'll agree, has a rather ovarian shape and possibly even 1 or 2 follicles. Now, this is known as the cobweb sign or suspended ovary. And this is where we can see the ovary is surrounded by fluid and held in place by the ovarian suspensory ligaments. Now, this appearance is pathognomonic of a peritoneal inclusion cyst. So peritoneal inclusion cysts exclusively occur in premenopausal women where the fluid originates from the ovary, but they have a previous history of pelvic or abdominal surgery, pelvic inflammatory disease, or endometriosis, and these cause adhesions and damage to the pelvic peritoneum, which is then less able to resorb the fluid. The cyst therefore develops within the boundaries of the peritoneum and the adjacent structures, and the configuration of the cyst is not conforming to an ovary. You can see the CT image here extending that top image all the way up the left flank, confined to the boundaries of the peritoneum. Is diagnostic, and as we said, known as the cobweb sign if you can see the ovary suspended within the fluid. So we have discussed chronic pelvic pain as a common condition, and that it is often multifactorial, looking specifically at the gynecological causes, but we must acknowledge that there are other causes of chronic pelvic pain, including bladder and bowel pathologies and many others. It's important that we use ultrasound to explore the possible origins of the pain, and MRI is there for problem solving and preoperative planning. So thanks very much for listening.
Good evening, everyone. My name's Narayan Karunathy.
My presentation is on pelvic congestion syndrome, diagnostic work and treatment. I'd like to thank the organisers for the invitation to join the UKIO.
So in my presentation, I'll be covering the following. Pelvic congestion syndrome. Spending a bit of time looking at the different types of pelvic congestion syndrome and venous insufficiency versus venous outflow obstruction as a cause for it. I'm going to go through the diagnostic algorithm that we use. Then I'm going to look at the imaging features and focus on the mainstay of imaging, which is transvaginal ultrasound and MRI scan, and finish with the interventional treatments that we use for this condition. We know that chronic pelvic pain affects a large number of women, up to 40% of women, and in particular prevalence in women of reproductive age is up to a fourth. This can have a huge impact on the quality of life for the patient. However, we know that the cause of chronic pelvic pain, as my previous speaker has alluded to, is there are multiple causes for it, not only gynecological causes, but other urological causes, GI causes, neurological, musculoskeletal, and psychiatric. So to sort of unpick that and come to the diagnosis is often quite challenging. In considering pelvic congestion syndrome, there's often quite an overlap with other gynecological conditions, and mainly endometriosis and pelvic inflammatory disease. But there are certain clinical characteristics of patients with pelvic congestion syndrome where you would then think quite likely of the diagnosis of pelvic congestion syndrome. And in particular, if women describe pain, chronic pelvic pain, that is worse on prolonged standing or at the end of the day, and at the same time describe that the pain is pretty much non-existent when they wake up and gradually becomes worse of the course of the day, that's highly suggestive. The pain is often exacerbated just before the onset of menses and pain after intercourse. And when pain is associated with physical manifestations of paralabial varices or upper thigh medial varices, as I'll show some examples in coming up, then those are all clinical features which are suggestive of a diagnosis of pelvic congestion syndrome. And therefore, it becomes really important to look at the patient in detail and go through quite carefully the history, the pelvic examination findings, and together with the transvaginal ultrasound and the MRI images. So, any patient referred with pelvic congestion syndrome, to me, I would see myself in my clinic, and lucky to have a clinic office as shown, and where I review all the imaging and discuss with the patient so that it's really putting together the clinical findings and the imaging findings together. When considering the etiology of pelvic congestion syndrome, what's typically thought of as pelvic congestion syndrome is often pelvic vein insufficiency or pelvic vein reflux. And as the diagram shows there, the refluxing veins, so the insufficient veins, can be any of a large plexus of veins, which include the left ovarian vein, the right ovarian vein, but also this large network of veins within the pelvis arising from the internal iliac vein, the anterior division, and commonly we see that the uterine veins, the internal pudendal veins, and the obturator veins can all be involved to varying degrees. But it's also important to bear in mind that the pelvic congestion can occur as a result of venous outflow obstruction. And when they occur in the left common iliac vein, it's often described as a May-Thurner syndrome. And when it occurs at the left renal vein, it's called a nutcracker syndrome. And the presence of either of these can result in a back pressure effect and result in dilatation and varices of the pelvic veins and or the ovarian veins. And these veins, once they dilate and become abnormal, can secondarily develop reflux. And so hence it's important in the diagnostic imaging workup that we look for the presence of these venous outflow obstruction. And so this is a diagrammatic representation and an intraoperative findings demonstrating what happens in the May-Thurner syndrome. The left common iliac vein is crossed by the right common iliac artery, and the vertebral body exists posterior to it, and the common iliac vein can become compressed by the common iliac artery, resulting in engorgement of that common iliac vein segment below the crossing of the common iliac artery. And that's what it looks like on the intraoperative findings. And the nutcracker phenomenon is when the left renal vein is compressed between the abdominal aorta and the superior mesenteric artery, as is shown in this illustration. And this compression can result in secondary hypertension almost in the left renal vein, and dilatation of the ovarian vein can occur to act as a collateral drainage to decompress the left renal vein. When considering the cause for pain in pelvic congestion, it's important to bear in mind that a number of factors could potentially play a role in causing pain. And we know that there's likely to be a hormonal factor to it, because we know that women who develop it of child-producing age, and we know that certain medical therapies which result in ovarian suppression can result in improvement in symptoms. As we will describe in more detail, there clearly are mechanical factors at play here which result in vascular reflux or venous reflux and possible contribution of venous compression as well. And in addition, there may be a neurological component to the pain, because the venous congestion or the reflux can result in a radiculitis, and the engorged venous veins can result in compression of nerve sheaths, causing pain also. And to really unpick this can be a challenge, but imaging therefore needs to sort of play a role where other factors are also taken into account. So we know, in terms of risk factors for pelvic congestion syndrome, pelvic vein insufficiency, there are a number of risk factors that have been described, but the most important one is pregnancies. We know that multiparous women, particularly if they've delivered the children by normal vaginal delivery, are much more prone to getting pelvic vein insufficiency. And so if we see a patient, so the typical patient that we see in clinic is someone with chronic pelvic pain who describes it as worse after prolonged standing or at the end of the day, and who've had more than one pregnancy, and may or may not have physical manifestation of varices, and those make up the vast majority of patients that we see, and whose, if the imaging features fit, would go on to have treatment. So, describing the diagnostic algorithm, we know that patients who are referred would have, we insist that they have a complete gynecological workup to look for other causes for their pelvic congestion syndrome. And once these have been excluded, from our perspective, the first line investigation is a transvaginal ultrasound. And that's to look for positive features of pelvic congestion, but also to exclude other pathologies. And we also go on to do an MRI scan of the pelvis, and I'll discuss the what we look for in the MRI scans in a minute. And if those do show evidence of pelvic congestion syndrome, we see the patient, we counsel the patient on possible treatment, and these patients would go on to have selective venography plus or minus intravascular ultrasound. And again, I'll describe intravascular ultrasound in a few minutes. So in terms of transvaginal ultrasound, this is the first line imaging modality that we use, and really the main things that we look for are as described in a very good paper by Park S.J. A few years back, and we're essentially looking for evidence of dilated parauterine, paraovarian veins, and there's no fixed size criteria. But we know that the larger they are, the more sensitive you are going to be in diagnosing pelvic vein insufficiency, and generally a cutoff of 6 millimeters is used. And the same applies for dilated ovarian veins, which over 6 millimeters in diameter. And obviously Doppler is very important, mainly to make sure that from a diagnostic point of view, what you're looking at is veins rather than cystic structures, and the flow characteristics can be very useful also. When you see retrograde non-pulsatile flow at rest and or Valsalva, that gives you a high index of suspicion that there is pelvic vein insufficiency. The other feature we look for is a varicose veins, a paralabial varices in the upper medial thigh. If you can follow those veins up into the pelvis on standard ultrasound, not transvaginal ultrasound, they again indicate likely pelvic vein insufficiency. The dilated arcuate vein in the myometrium is again a feature of pelvic congestion, but I'll touch on that in a minute, because there's a bit of nuance to the arcuate vein in our experience, at least. And so on transvaginal ultrasound, there's a typical dilated veins that you will see. The asterisk there marks the ovary, and surrounding the ovary, you see these numerous dilated veins. And when you put Doppler on them, you can see that they're clearly venous flow. And it's important to differentiate venous flow from a pulsatile artery flow, because the presence of pulsatile arterial flow may indicate another pathology like an AV malformation. And this is a view of the uterus, and you see this large vein that is crossing the anterior uterus from left to right. This is a picture of a dilated vein with Doppler venous flow, and on Valsalva there's reversal of flow in the vein, indicating reflux. And if you're able to demonstrate that on Valsalva, again, that's a use of the Valsalva technique is really useful to demonstrate that reflux. This demonstrates two images which show quite markedly dilated parametrial veins, and the Doppler also demonstrating the color flow within those veins. And this again is a feature of pelvic vein varices. And this is the image showing the arrows point out the dilated arcuate veins within the myometrium. And when you see this again, there's to have an eye index of suspicion that that could be pelvic congestion syndrome when these veins are communicating with varices. This is an interesting paper looking at the patterns of reflux in the various veins, and the study looked at the presence of reflux in the internal iliac veins, either being right or bilateral, and involving the ovarian veins. And interestingly, they found that by far the most common pattern of reflux was bilateral internal iliac vein and left ovarian vein reflux, followed by bilateral ovarian and bilateral internal iliac vein reflux. And the third most common pattern was bilateral internal iliac vein reflux. So it's relatively rare that you only get isolated ovarian vein reflux in these patients. And this has an implication in terms of treatment, that when you look for these refluxing veins, it's really important to look for both ovarian vein reflux and also evidence of internal iliac vein reflux. Moving on to MRIs, we know that MRI is a very good imaging modality for looking at pelvic pathology, but when it comes to pelvic congestion syndrome, a number of studies have looked at the sensitivities and specificities, and generally it has a high sensitivity but low specificity. So to say that, quite commonly you'd see what looks like dilated veins within the pelvis, and that they may not always may mean that there is pelvic congestion syndrome. So the way our pragmatic approach to using MRI is really to use it to exclude other causes of chronic pelvic pain, and also to use it to look for features suggestive of venous outflow obstruction, because as we described, the presence of venous outflow obstruction could be a form of manifestation of pelvic congestion. It's also really useful to look for a presence of paralabial varices and high varicose veins to see if these communicate with the pelvic veins. And I'll show you some examples in a minute. So these are two images from standard high-res T2 axial images, which demonstrate quite dilated veins within the pelvis. In the first case, surrounding the uterus, and in the second, surrounding the vagina. But again, this may be seen quite commonly, and the significance of this can be hard to work out. In this patient, there's clearly the pattern of varicose veins that you see here, which show that they are high medial varicose veins and the more medial of the two, there's clear communication with a pelvic paralabial area, whereas the more lateral one appears to be heading towards the saphenofemoral junction. So when you see a patient with this pattern of varicose veins, you'd have a reasonably high index of suspicion that there is a pelvic vein insufficiency. And this is the MRI scan on that patient, which shows that what you see quite commonly is the dilated parametrial veins, and this shows these dilated veins extending surrounding the vagina. And as you can follow them down, you can see that they communicate with the paralabial varices that this patient clearly had, bilaterally on the right and the left. And as we go down even further, you can see that these then communicate with these high medial thigh varicose veins. This patient also, as we'd seen from the clinical photo, had dilated peripheral varices crossing the front of pubic bone and extending towards the saphenofemoral junction. And this is more anteriorly. And there's a cross-pelvic vein superior to a pubis and multiple veins communicating with her saphenofemoral junctions. And so when we do a venogram in this patient, you can see from the first image there a very markedly dilated paralabial varices that that would correlate with what we were seeing on the MRI images. And then the second sequence here from the left side again demonstrate that quite large network of paravaginal varices that we had seen on the MRI scan. These are further images which where I've selectively cannulated the uterine vein and demonstrated quite marked refluxing parametrial network of varices. And on this next image here, these parametrial paravaginal varices are communicating with the paralabial varices that we had seen on the MRI scan. This and changing focus, again, as I mentioned, the MRI scans used to look for other pathologies and for venous outflow obstruction. And this may be, again, something that you see quite commonly and in the right clinical context would raise suspicion of possible venous outflow obstruction. What we're seeing here is a balanced steady state free precession MR venogram with no contrast. That is a standard protocol we use to image veins. And here we can see the right common iliac artery and the vertebral body, and the left common iliac vein crossing between the two structures to join the right common iliac vein, and appears compressed as it goes across. And when we did a venogram on this patient from cannulation of the left common iliac, left common femoral vein, we can see contrast flowing up the external iliac vein, and you get a very distinct impression of the right common iliac artery crossing that left common iliac vein, causing a extrinsic compression of that vein. And as a result of that compression, you have these markedly dilated collateral veins which are crossing over in and filling the contralateral common iliac vein, and also filling these paraspinal paravertebral veins as collateral networks. And hence, if one were to do a transvaginal ultrasound in this patient, you are very likely to see dilated veins within the pelvis, but the underlying pathology is not necessarily pelvic vein reflux. It's more a secondary phenomenon of the presence of venous outflow obstruction. And like I said, intravascular ultrasound can be very, very useful in these cases. And this is the intravascular ultrasound demonstrating the compressed common iliac vein in between the structure at 12 o'clock, which is the common iliac artery, and the structure between about 6 o'clock and 9 o'clock, which is the vertebral body. And for the sake of completion, again, this shows a dilated left renal vein and there's marked change in caliber as it passes between the abdominal aorta and the superior mesenteric artery. In a patient who previously had surgery and transposition of a retroaortic left renal vein into an anterior position. So again, this sort of configuration is commonly seen, and the clinical significance of this is hard to understand, but again, it's as always in this cohort of patients, it's about very much putting together the clinical features with the imaging findings, and in the right clinical context, knowing that this may well be a significant finding. And this is a venogram which demonstrates compression of that left renal vein and secondary collateral filling of that paraspinal paravertebral network of veins. So in terms of treatment, the treatment is tailored depending on what we think is a primary pathology. Is it pelvic venous insufficiency, or is it venous outflow obstruction? When we think that the cause for the pelvic congestion is pelvic venous insufficiency, the primary treatment modality we use is embolization, sclerotherapy with coils and liquid agents like sodium tetradecyl sulfate. Now, there are various reports of people using lots and lots of coils. Our practice is very much moved to one where we primarily use sclerosant agent, liquid sclerosant agent, with very sparing use of coils. And I'll come on to our outcomes in a minute. In terms of preparing the liquid sclerosant agent, is a very straightforward way of doing it. The sclerosant, it's the same that we use to treat for varicose veins. It's called Fibrovane or sodium tetradecyl sulfate. It comes in a 2 ml vial. We drop the sclerosant and mix it with air with use of a 3-way tap, and so it's a back and forward sort of a movement to create a foam. And once that foam is created, that's then injected into the area that we want to sclerose, be that the parametrial, paravaginal, or refluxing veins. And so this is, again, a typical case where I've cannulated the uterine vein and demonstrated these hypertrophied refluxing uterine veins on the right side, and on the left side these dilated paravaginal network of varices, and these are the typical veins that we would then go on and treat with sclerotherapy. This is another nice example of a dilated obturator vein that was clearly communicating with this upper medial thigh varicose vein, which I've then selectively cannulated, and from here I'd be able to sclerose that with good clinical effect. We would also look for and treat ovarian vein reflux, and the way we treat it is again very similar. Practice varies slightly until some people would use coils to embolize the whole vessel, and in this case I've opted to embolize the bottom with a coil and then backfill the entire vein with the liquid sclerosant agent up to the level where the ovarian vein forms a confluence with the left renal vein. In terms of outcome, this is a meta-analysis that was published recently, which looked at studies involving more than 50 patients, and these range in number from 50 out to 200 treated with quite typically with sclerosant agent and or coils, or the vast majority had coils treatment, and all of the studies have demonstrated a very good clinical outcomes, which vary in number from about from 80 up to 96%. But it's important to recognize that there may well be a small proportion of patients where you make no difference in symptoms, and a very, very small population of patients in whom you may make the pain worse. And that comes back to the multifactorial nature of the cause for these patients' pain. And therefore, when you counsel these patients, it's very important to go through the potential risks and the potential benefits quite clearly. Coming on to the treatment of venous outflow obstruction, as we described, this is again a typical case where we've done a venogram from the left common femoral vein and demonstrated an obstruction of the common iliac vein and secondary cross-filling of the pelvic collateral filling, the contralateral internal iliac vein, common iliac vein, and that forms the outflow for the obstructed left-sided system. And hence, in our experience anyway, when we see the dilated arcuate veins within the myometrium, they seem to often indicate this sort of configuration, and therefore we have a reasonably high index of suspicion, or certainly would want to do an intravascular ultrasound to make sure that there is no venous outflow obstruction. Because if you were to go in and treat these cross-pelvic collaterals and block these off, you run the risk of making the situation with the left leg venous outflow worse. And therefore, the algorithm of treatment for us anyway is to look at this in more detail with intravascular ultrasound. And this is the pullback where we've pulled the catheter back from the IVC, which is the structure demonstrating peristalsis or movement with respiration. And here you come into the tight, compressed common iliac vein. And then as we pull down lower than that, we come into a normal caliber, lower common iliac, external iliac vein here, and down into the common femoral vein. So therefore, once we've identified that or diagnosed that as the point of stenosis, we then go ahead and treat that by placement of a stent to open up that common iliac vein. And here we place a large caliber stent, about a 14 or a 16 millimeter diameter stent, to ensure that there is now inline flow from the common femoral external iliac vein up into the common iliac vein and into the IVC. So in summary, I'd like to say that diagnosis of pelvic congestion syndrome requires really careful history taking and examination and correlation of these with imaging findings. Transvaginal ultrasound and MRI are mainstays of imaging and need to be interpreted in the context of the clinical findings. Transcatheter embolization is gaining popularity with good reported clinical outcomes. Thank you very much, and I'm open to taking questions now.
Hello. First of all, I have to apologise. I think in the break my microphone wasn't working, so you could see me but couldn't hear anything. Thank you both for excellent talks on your areas. And now hopefully you can see and hear me. If we move to the questions that have been asked, the first one is for you, Sue. Is an anteverted cervix with a retroflex uterus on ultrasound sufficient evidence to report increased suspicion of endometriosis?
Okay, well, can you hear me first? I think it's just to say that when you see that on the transabdominal view or even on the transvaginal view, that you should really make an effort to look for endometriosis, because that fibrotic retroflexion is a really typical finding in ultrasound. And so that is your point, that if you were going to just be minimalist and do uterus and ovaries and finish, then you definitely need to do the uterine sliding sign, and you need to be putting the probe into the posterior vaginal fornix, looking along the torus uterinus and the uterosacral ligament. So it's to make you suspicious, but it's not diagnostic, no.
Thank you. The next question is also for you. Could you please explain the difference between endometriosis and an endometrioma?
Okay, so in 10 seconds. So endometriosis is the overarching pathology where endometrial stroma and glands are outside of the uterus, seen all over the pelvis and elsewhere. Endometrioma is when it affects the ovary, and we typically see chocolate cysts, which is repeated episodes of bleeding causing a big blood-filled cyst on an ovary.
Sorry, just unmuting myself. Thank you. And I think is it 80% of endometriosis is thought to be ovarian and endometrioma? Another question for you, Sue. Would you be able to give an idea of what your MRI protocol for endometriosis is?
The MRI protocol for endometriosis? Yes, so we would do 3-plane T2, so sagittal, axial, coronal. I know some people like to do an axial oblique so that they can go along the torus uterinus, but we find that just for uniformity, it's just easier to do a straight coronal, and then T1 and T1 FAT-SAT. Because we don't supervise our scans, pretty much all our patients will get DWI as well, which is of some help.
This is my question. What are your thoughts on vaginal and rectal contrast?
We don't do it. We don't do it. For vaginal, the gynecologist can look, so we don't really need an MR for that. And for rectal, it hasn't improved our sensitivity at all. And looking at the papers, they're split. But the people who instill gel are passionate about it, and those who don't see the need for it.
To a degree, I think the jury's out, so it's whether you want to or not. Okay, so I think we're now moving on to questions. Moving across to questions for Narayan about pelvic congestion syndrome. The first one, I think, probably for both of you to comment on. I'm just going to read it out. Pelvic pain is a complex problem. I see patients with pelvic congestion syndrome with no obvious cause associated with pelvic pain, either on ultrasound or CT. I have always reported the pelvic venous congestion as a possible cause of the pain. What are your views about the significance of pelvic congestion?
So did you want me to...
Hands up who wants to take it first.
Well, if I could maybe start off that discussion, I think it's it's a very interesting topic, and I think pelvic congestion is always considered in our practice, at least, as once other diagnoses are excluded. And then it's very much putting together the clinical picture with the imaging findings. So it's very much a diagnosis of once other more serious causes have been excluded. But clearly there are some clinical features which are very typical of pelvic congestion, and imaging really is to support that clinical picture in our practice, at least.
Do you want to add anything?
He's the expert, huh?
There's a question here asking whether you have a gynae radiologist review all the pelvic scans done for pelvic congestion.
That's a really good question. So in our practice, patients get to us once they've been through a full gynecological workup, and as part of that full gynecological workup, they've invariably had a gynecological pelvic MRI scan done already. If they haven't had a gynae pelvic MRI scan done, we do a two-part exam, which includes a gynae pelvic MR, which the gynae radiologist reports, and then an MR venogram, which I invariably report. And the additional sequences that we do are mainly the, high-res T2s are usually already done. We do an inversion recovery, and we find that the balanced steady-state reprecession acquisitions are also very useful processing there. We don't give any gadolinium to do any post-gadolinium acquisition.
Okay, well, that was another question. What was your protocol for scanning? Another question for you, Narayan. How important is it to include pelvic congestion on an ultrasound report on an asymptomatic or a symptomatic patient?
Yeah, I think that's I think the more you look, and I think certainly on MRI scan, the more you look, you will find a number of dilated veins. But I think there are the presence of dilated veins which show retrograde flow in our opinion, in my opinion at least, and I guess I'm sort of slightly biased, it's certainly worth mentioning, because a lot of women with chronic pelvic pain, and I'm sure both of you experience this, go from place to place to place where they don't get a diagnosis for a long time, and certainly by the time they get to me, it's often many months or years down the road. So I think at least flagging that as a possible cause once other more serious causes are being excluded is, I think, in my opinion, worth doing.
What is it that that a sonographer might put in their report to help with the diagnosis of PCS? Are there specific things that you would want them to look for?
Any dilated veins, either ovarian or uterine veins greater than 6 millimeters in diameter, demonstrating either retrograde flow or retrograde flow on Valsalva, would be worth commenting, in my opinion.
And sorry, another question about the ultrasound. What's the spectral waveform in PCS without Valsalva?
It's just a continuous waveform. And then when you Valsalva, it reverses. And I showed a picture of it in my presentation, so you may want to, the person who asked the question, they may be wanting to look through the presentation, which I think is available.
Yeah, I think they're now, the PDFs are now available for viewers, delegates to download. So there's now a couple of questions about the technique of your embolization. So firstly, could you describe the technique for liquid sclerosant injection to prevent uncontrolled reflux further up, e.g. into the lungs, etc.? Do you use Valsalva? What about if close to the main IIB or CIB?
That's a great question, thank you. So I think the most important thing when we're doing foam injection is to get very distal. We would not contemplate injecting if we're in the main internal iliac vein. You really need to get, as you saw from some of the catheter positions that I showed in some of my pictures, we're very distal into the uterine plexus. And when you do a contrast injection, you want to see that sort of refluxing pattern. If you see a pattern where there's prompt flow up the internal iliac veins towards the heart, there's clearly an indication that those veins are not refluxing. And so, yeah, sure, if we're in some down, there's two things we can do. One is we can use Valsalva, but what I've occasionally had to do is use an occlusion balloon. And I place the occlusion balloon about where my catheter position is, blob the occlusion balloon to prevent flow up the internal iliac vein, and then do the injection sclerosant. The times I've had to do it are not typically in pelvic congestion syndrome patients who have refluxing veins. I've had to do it in some occasions when I've treated venous malformations within the pelvis involving the bladder or the rectum. One other thing you can do is you can place coils to prevent outflow as well, but again, I've not found that to be particularly necessary.
Thank you. Sorry, one last question, and then we have to wrap up the session, unfortunately. And it's related to whether you get much recurrence using STS.
Yeah, I think. I always follow my patients up. I see them at 6 weeks, and then at 3 months, and then onwards if required. And touch wood, I think you're not trying to get rid of all the veins. You're not trying to get a perfect result here. You want to reduce the volume of venous reflux to a level that the symptoms are manageable. And for sure, there, in about, I'd probably say about 20% of women, I've had to do a follow-up second procedure to complete the job, and that's, you accept that as what we do. But I think I err on the side of using STS rather than coils, because I think coils, can create a problem on its own.
Thank you very much. Unfortunately, we need to bring the session to an end there because there's another one ready to go very soon. First of all, I want to just thank both of you for excellent talks and for the Q&A session, and to all the delegates who've attended the meeting virtually. The PDFs of both talks are available to download. There's a download area at the bottom of your screen. And thank you. I hope you'll join the next session, which is next week.
Bye-bye. Thank you.